So in chapter 5 and 6, we're really going to talk about the crux of this class, and that is the immune system. And in chapter 5 here, we're going to talk about our first and second lines of defenses, and primarily we're going to be focusing on the second line of defense, which is inflammation and how inflammation actually works and the repair that is done. And so you can see that this foot is actually inflamed, and that's because we can see the cardinal signs of inflammation, and we'll talk about those here in a moment. So, in this chapter, you should be able to compare and contrast innate and adaptive immunity. You should be able to compare and contrast acute and chronic inflammation with special attention to the timelines of the response. You should be able to name the major chemical mediators of inflammation and explain how they interact to intensify the inflammatory process. And this should include both cell and blood plasma derived mediators. Describe the harmful effects of inflammation and explain why it is sometimes necessary to suppress the immune response. And compare inflammation and infections. You can have inflammation without infection, but infection will always cause inflammation. And name some of the terms used to describe these infections. So let's look at the local and systemic effects of inflammation. Local effects is eventually we're going to get dilation of the capillaries in the area of cellular injury. This will cause increased blood flow, increased warmth, and redness in the area. Also, as the capillaries actually increase in size diametrically, this will cause the endothelial cells to actually spread apart from each other slightly, and this will increase capillary permeability. This leads to the extravasation of fluid from the bloodstream, which in turn leads to swelling and the formation of exudates. We also will see attraction of the leukocytes to this area of injury because in order to heal, we are going to need to clean this area up. And so leukocytes will migrate to the site of injury and begin their job of phagocytosis. They will actually adhere to the endothelium of small blood vessels and undergo a process called diapedesis to get out into the tissues where they then function to clean up. Systemic effects of inflammation will include oftentimes systemic fever, as well as increased or decreases in the numbers of leukocytes circulating in the bloodstream. So what is innate immunity? Well, innate immunity has a quick response. It is a predetermined array of signals, and it includes both the first and second lines of defense. The first lines of defense will include those things like our skin, which is a physical barrier to microorganisms, or the stomach acid within the stomach, which is a biochemical barrier. And later we'll talk a little bit about some of these. The second line of defense, well, what happens if you cut your skin? That's where inflammation and phagocytosis will come in. And with the innate responses, you are born with those responses, and everybody does them the same way, no matter what is causing the injury to the cells. Whereas adaptive or specific immunity is much slower, but it can adapt to changes. The other big thing about the difference between adaptive and innate immunity is the adaptive immunity creates memory to what we have been exposed to. And this is our third line of defense. Now, let me say, the second and third lines of defense work hand in hand with each other. It's just that inflammation is going to be an immediate response, whereas the adaptive response, depending upon whether we've been exposed to whatever this infection is or whatever the microbe is, will determine how long our response may take. It may only take a couple of days to actually out to 10 days. So let's look at inflammation. It protects against physical injury, so cutting yourself, chemical injury, such as a chemical burn or uh, something along those lines, microbiological injury. So again, inflammation does not care whether the injury occurred because of physical trauma, intoxication, or even deficiency. Any of the three that can cause cellular injury will cause an inflammatory response. Acute inflammation occurs immediately upon the injury, and typically the acute inflammation will only last less than 2 weeks in duration. We'll see vascular and cellular components. The cells involved are going to include mast cells of all of the connective tissues except blood, and the cell that will actually operate as the mast cell does in the other connective tissues is going to be the basophil in the blood. Platelets performing several functions, one of which is very important, is the platelet plug, neutrophils, and macrophages. Now, there are 5 characteristic signs and symptoms of inflammation. First of all, we're going to see a redness or erythema. This is due to the increased blood flow due to vasodilation. The localized heat will also be due to that vasodilation. So dilated blood vessels and the slowing of blood through these dilated blood vessels will cause both the localized heat and erythema. We'll see edema of the local area, and this is due to the vascular permeability. As the blood vessels dilate, they become leaky, and we will see more fluid exiting the blood vessels into the tissue space. This results in edema and eventually will become part of the exudate. Pain. Pain is a good thing. It lets you know that you have breached a first line of defense. Prepare to die. Because if inflammation isn't right there, there is a potential that you could actually die from what might be trying to enter the body. This can be due to irritation of the nerve endings directly by the injury, or it can be due to chemicals that are being released in this area from some of these cells. And then the fifth kind of sign symptom is loss of function. And usually this is temporary, but could possibly be permanent based upon the amount of damage. The acute inflammatory process on the cellular side. Mast cells are the driving cell of inflammation. They are going to be the first cell that responds. And the way that they respond is to release a whole bunch of chemical inflammatory mediators. Mast cells are found in all connective tissues except for the blood. And again, we now believe that the basophil actually fulfills this function in the bloodstream itself. We'll see polymorphonuclear leukocytes, and these are basically the neutrophils and to a lesser degree the eosinophils. These are going to be the first actively phagocytic cell in acute inflammatory response. And the reason for this is one, they are most numerous in the bloodstream. Because we have bleeding with inflammation, we're just going to see a lot of these neutrophils get out there and immediately start phagocytizing things. I call the neutrophils the Marines of the immune response. The reason for this is simply because they're going to be the first ones in and some of the last ones that are out. Neutrophil numbers usually peak somewhere between 24 to 48 hours after the injury has occurred. Mononuclear cells, and these are the blood monocytes that will exit the blood vessels and go into the tissues to become the large macrophages. They actually are the secondary phagocytic cell. They will actually start to show up within the first 24 hours, but their numbers don't normally peak until somewhere around 3 to 5 days after injury has occurred. They are longer lived than the neutrophil, and so they can clean up a lot more debris. So what are the outcomes of inflammation? Well, it depends on the amount of tissue damage that was done. I can see a very severe inflammatory process. I get a lot of tissue damage, and this oftentimes will then cause replacement of the damaged cells with scar tissue. This also is determined by what tissue was damaged. If I damage a labile tissue, let's say epithelial cells, oftentimes they heal by something known as regeneration. Uninjured surrounding cells simply increase the amount of mitosis they normally would be undergoing and replace the cells that were lost due to the damage. So we get very little scarring with regeneration. However, some other tissues, such as the permanent tissues of the brain, nervous tissue, cardiac muscle, and skeletal muscle, known as permanent tissues because they don't undergo mitosis as mature cells, they actually will not be replaced by mitosis or hyperplasia of the normal cells. They will be replaced by connective tissue, scar tissue. With mild inflammatory process, oftentimes this is very self-limiting and subsides with tissue resolution. Outcomes, then we see regeneration, and this is simply where we are going to replace the cells lost to injury with normal cells. So regeneration will allow us to replace normal cells, and we'll see normal structure and function returned. Whereas repair, we're not replacing the cells lost by mitosis. We're actually laying down scar tissue. And so this, we replace the damaged tissue close to normal structure. But here's the thing, it's not going to function normally anymore. So regeneration returns the injury to normal structure and function, while repair structurally heals it together but does not functionally work anymore. And areas of destruction are replaced by this scar tissue will simply then mature over time to help hold the area together. Mediators can intensify this inflammatory process and actually then again determine regeneration or repair. And oftentimes in inflammation, it builds upon itself. Some mediators will actually generate more mediators from other cells, which will then cause more mediators from other cells, and it just builds from there. And so this is one reason why sometimes we actually need to dampen the inflammatory response. So this is our figure here. So again, don't care what was the cause of the tissue injury. We have tissue injury occurring. So the mediators of inflammation from the mast cells and others will be released. We will see capillary dilatation eventually. The first thing we see is when we cut a blood vessel, the blood vessel actually constricts. So the very first immediate response of broken blood vessels is vasoconstriction. Then we're going to see the mediators of inflammation being released, and they cause the capillary dilation. This increases blood flow to this area for both cleanup and healing. We'll see increased capillary permeability with the capillary dilation. We get extravasation of fluid and sometimes cells like the white blood cells. We'll see chemicals released that will attract the leukocytes. These are known as chemotaxic factors. And so more neutrophils, macrophages will migrate into this area of injury for cleanup. And we can see a systemic response of fever or leukocytosis. And all of these then will lend to our signs and symptoms of inflammation. Now, chronic inflammation is any inflammation that lasts longer than 6 weeks. This is a cellular response that does not include neutrophils. What we'll see in chronically inflamed areas will be monocytes, macrophages, and lymphocytes. if the neutrophils were there, in other words, if this chronic inflammation was caused by an acute inflammatory response that did not get rid of the etiological agent or what was causing the injury and became chronic, the neutrophils are long gone. But oftentimes with chronic inflammation, this is kind of a slow, insidious onset of injury, and so we really won't see a lot of neutrophil or even mast cell response. There are chemical mediators that are released by the macrophages and lymphocytes, and one of the things that the body will try to do with chronic inflammation is wall that area off. So we'll see lymphocytes, which are the smaller cells here, and we'll see plasma cells, which are the activated B lymphocytes we'll talk about later, and we also will see macrophages in this area. And the macrophages are like, this is probably one here, this is probably one, this is another one. So there's some of the larger cells that we see here. We also will see blood capillaries in this area because we do have to have nutrients and oxygen for these cells to try to do their job. But the body will actually try to wall this off with connective tissue fibers. And so oftentimes with chronic inflammation, we have these walled off areas known as granulomas. And this is basically where there is a standstill between the immune response and whatever's causing the injury. So neither one is winning until maybe years later. Now, what are some of these chemical mediators of inflammation? Well, we have a group known as cell-derived mediators, and most of these come from the mast cell, but not all. So the mast cells actually are filled with granules normally, and these granules are filled with primarily histamine. Histamine is a potent vasodilator. When injury occurs, mast cells release these granules of histamine into the extracellular fluid compartment. This process is known as degranulation of the mast cells. Histamine and serotonin are also released from activated platelets, and so histamine from the platelets will simply assist the histamine from the mast cells. Serotonin is also a vasodilator, even though not quite as potent as histamine. When the mast cells degranulate, they also gear up a system that makes a couple of important groups of chemical inflammatory mediators. One of these groups is known as the prostaglandins, and they have a variety of effects, one of which they are going to be vasodilators as well as increased vascular permeability, but one group of the prostaglandins actually stimulates nociceptors. So early on, this is what is going to be one of our chemical mediators of pain. The leukotrienes are also synthesized in the mast cell once they are activated, and both prostaglandins and leukotrienes are synthesized from one of our amino acids called arachidonic acid. Mediators from blood plasma will include bradykinin from the kinin system and complement proteins from the blood complement system. And again, we'll talk about these a little bit later on. Complement can be activated by antigen-antibody reactions, and we'll talk about the antigen-antibody reaction actually in the adaptive response. Or complement can be activated by a series of proteins in the blood that interact in a regular sequence, or they may actually be, the complement may be activated by something in bacterial cell walls as well. So it's the interaction of these mediators of inflammation that will cause our signs and symptoms. And so they will actually feed upon each other. So mediators released from the mast cells, from the activated platelets from macrophages that will actually cause mediators from the complement to be activated, which in turn will cause more mediators to be released from more mast cells. And the same thing with the kinin system. And so this literally feeds upon itself, and that is why sometimes we need to actually dampen this response down by using oftentimes anti-inflammatories such as an antihistamine or a nonsteroidal anti-inflammatory drug. Now, lysosomal enzymes in the antigen-antibody reaction. In the phagocytic cells, we have the lysosomes, which contain digestive enzymes. And neutrophils and macrophages have numerous or can make numerous lysosomes that will then actually fuse with the phagosome brought in through phagocytosis to form the phagolysosome. The digestive enzymes will then work on whatever's within the phagolysosome to break it down. Antigen-antibody reactions will activate complement proteins that will generate more inflammatory mediators. Harmful effects of inflammation. Well, could inflammation, as it feeds upon itself, actually cause more tissue damage? And the answer is absolutely yes. So again, sometimes we want to actually dampen this inflammatory response. Sometimes, again, I mentioned antihistamines and the NSAIDs, we can actually use corticosteroids. And corticosteroids will actually suppress persistent inflammation. I use corticosteroids a lot of times when I know that I have inflammation in nervous tissue. Because one, it gets there faster than some of the NSAIDs and certainly faster than an antihistamine. And so in other situations, I may not want to use the corticosteroid because it can actually delay healing. Now, exudates are the fluid mixture of protein, leukocytes, and tissue debris found in the extracellular space from the edema and the destruction of cells and the cleanup process. A portion of each exudate has got protein and inflammatory cells, but they vary depending on which type of exudate we see. Serous exudate is primarily serum from the blood. There's no cells, very little protein, and usually this is just simply clear fluid. Purulent exudate is largely from inflammatory cells, primarily neutrophils with macrophages, and this is actually pus. Now, purulent exudate usually occurs due to infection. Fibrinous exudate is where the fluid is actually rich in the protein fibrinogen, which actually then is coagulated and forms fibrin strands. It really doesn't form a blood clot unless there's red cells in there as well, but this fibrin produces a sticky film on the surface of inflamed tissues. Sometimes this can result then in adhesions of surfaces together because the fibrin will actually eventually become scarred in. And then I will mention hemorrhagic exudate, which is just frank blood in the tissue. So I said you can have inflammation without infection, but infection will always cause inflammation. The suffix itis indicates an infection or inflammatory process, such as appendicitis, hepatitis, colitis. Cellulitis is where an acute inflammation is spreading from a site where infection has occurred, especially throughout the subcutaneous and fascial planes regions of the body. Abscesses often form where we have an infection that's associated with the breakdown of tissue, the formation of pus, but the body actually walls this off with a fibrin connective tissue capsule. And these abscesses can actually get very, very large and be filled with lots and lots of purulent exudate. Septicemia is an overwhelming infection where pathogenic bacteria gain access to the bloodstream and begin to actually grow and multiply. Pathogenic is anything capable of producing disease where it is located. And virulence is a measurement of the severity of disease of that pathogen. A host is any affected individual or animal. Now, infection involves a relationship between an invading organism and the defenses of the body. So we actually have this balancing act where the body defenses, and this would include all three lines, and the virulence and how much of the infectious organism, so the infective dosage that gets in. If we have a highly virulent organism and a high infective dosage of that organism, then this actually tends to tip down towards disease. Whereas if this is not a very virulent organism and or I have a low dosage of the organism, then the body defenses tend to overcome it and we get resolution and healing. Stalemate between these two, where they kind of remain balanced and neither one is swinging towards the other side, is really that stalemate, and that's when we get chronic infection and chronic inflammation. Factors that influence the outcome then are the virulence of the organism and the infectious dosage, the number of invading organisms. It will only take one rabies virus to cause rabies because it is a highly, highly virulent organism. Whereas certain forms of measles, because it's not as virulent, will take a lot more to actually cause disease to occur. And what is the host resistance? Are you sick with something else right now? Okay. Do you have an immunocompromising disease of some sort? Okay. Did you just not inherit a good immune system? So all of those play a role in this balancing act as well. Now, chronic infection is really in the state in which the pathogenic organism and the host are evenly matched. Oftentimes, chronic infection is relatively quiet. It causes kind of that smoldering chronic inflammation associated with repeated attempts at the body at healing. Predominant cells in these areas of chronic infection inflammation include lymphocytes, plasma cells, and again, the macrophages. So, how do the mediators of inflammation function? What are the possible outcomes of acute or chronic inflammation? An exudate high in fibrinogen can coagulate, that produces fibrin that causes a sticky film on tissues that causes normally separated tissues to adhere together. And this is the result from the production of what type of exudate? So in the next chapter, we're going to discuss the adaptive response, and then we're going to look at when things go wrong.